he is the new guy. He's the new gastroenterologist at Bozeman Deaconess GI Clinic. And then he just relocated from Portsmouth, Virginia, where he was at the Naval Medical Center there. So we're very happy to have him here and participating today and introducing him to the community here. So thank you, Dr. Gentry.
She took my line. But anyway, my name's Andy, and I've been sober for 24 hours. I saw the coffee, I thought it was me. So anyway, they asked me to talk about the risks and benefits of biologics. So the biologics, it's kind of they're designer drugs. They're made specifically to talk about and interfere with that immune pathway that goes through and causes all these diseases. It's usually he talked about the step up and step down. You know, we're kind of forced to use the step up therapy rather than a step down therapy. Step up meaning you fail other ones and then get to the biologic therapy is kind of the last resort. 7. Oh, I'm sorry. Yeah. I am not on the slides. The slides that were out of date, so I've updated them quite a bit. So just bear with me. So when you see something that's not in your handout, it's because I haven't. But there are risks to this. Just anytime you interfere with the immune system's there for a reason. And if you interfere with it, you've got a risk of infection or side effects, just like any other drug. You know, just like any other medication or either food. You know, I eat Brussels sprouts, I throw up. You know, I was abused as a child. No, my parents made me eat it. So here's a balance of inflammation and normal function. So you got to take a look at this slide. I'm going to use this slide a lot throughout this presentation. So if you look at this, you have intercellular pathogens. Intercellular pathogen. Your body has to recognize everything that comes into your mouth. It has to realize that if it's a friend or a foe. So I want you to think about your lumen of your intestinal tract is not this smooth surface, but more like blades of grass. You've got millions and millions of receptors. It's got to see these things, see if it's nutrition. Nutrition, I accept it and I send it on to the liver. If it's a foe, if it's a virus or a pathogen, it's got to sit there, say this is a pathogen, this is a bad pathogen, I've got to kill it, and then it sends out these signals. These signals, those are all these interleukins, tumor necrosis factor alpha, interleukin 13. You can see them, there's lots of them. And all these different biologic therapies interfere with, here's TNF-alpha, that's the one. We're going to talk about interleukin 4. We're going to talk about interleukin 12 and 23. These are all these biologic therapies that are coming out on the market or soon to be approved for IBD that we're going to try to interfere with and interfere with this process. But you can still see that there's other ones that still exist. So your body will find a way to fight off these pathogens one way or another. And that's who's the young lady who talked about the drugs failing the patient. It's because maybe it's not this pathogen that your body selected. There's over 70 genes that are leading to Crohn's disease. And if we just interfere with this one TNF-alpha, maybe your Crohn's disease is going on a different pathway, okay? Because your genetic predisposition sets you up for that pathway, okay? And if you look at it, your body does a great job. So these are the normal, healthy poop people. So, and then the ulcerative colitis patients are over here. Crohn's patients are way over here. So your body's immune system is interfering with your normal microbiotic flora that lives in your gut. They're going to talk about this as a complete lecture later this afternoon. But you can kind of see when they do these poop studies and they look at the analysis of people's poop, it's different. People with inflammatory bowel disease have different poop than other people, okay? But you need this to exist. So I tell people all the time, my son, he used to eat gum, you know, off the side of the street. And at movie theaters, it was on the bottom of the seat. I'd see him picking gum and eat it. You know, he's healthy. He's kind of weird, but he's a healthy kid. Because his immune system took care of all the stuff that he ate. He played in poop. You know, we throw him in a sandbox, and the neighbor's cat was in there using it to defecate in. He's a healthy kid. But your immune system does a great job, and we've evolved as a species to take care of all these things. Okay? So we're first going to talk about the first one that came out on the market is the tumor necrosis factor alpha. Okay? So you can see the big red line in there. And again, that's only one of probably 50 different possibilities. So the mechanism of action, I want you to think of these tumor necrosis, these interleukins and these tumor necrosis factor alpha as an invitation to a party. Your immune system sees this and your gut bacteria sees it, or your gut lining sees these things, and it sends out an invitation to your immune system to come, okay? And that's this invitation is this tumor necrosis factor alpha. Okay, so this invitation goes out, and it hits a cell, and the cell gets all excited. Hey, I've been invited to a party, I gotta go find the party. Where's the party, where's the party, where's the party? So the way these anti-tumor necrosis factor, I know it gets this anti, and then tumor necrosis factor alpha is what your body makes. So the anti-tumor necrosis factor medications, which we'll talk about in a second, so that's the adalimumab, infliximab, Remicade, Cimzia, okay, Vedolizumab, all the ABs, a lot of the ABs, are this anti-TNF-alpha, okay? So it's an antibody that we all have in our bodies. We give it to you, or we give it to patients, and it stops this invitation from existing, okay? The downside of that is that you want that invitation if you really, truly have an infection. So this is the anti-TNF-alpha antibodies, the Humiras, the Cimzias, the Remicade, and the Simponi. Please forgive me if I don't pronounce words that you're used to hearing, because in my head I hear them correctly. And the adalimumab, the certolizumab, the infliximab, and the globimab are the ones that are FDA approved right now for inflammatory bowel disease. Okay? There's two ones out there that are anti-alpha, which we're going to talk about next. Oh, I'm sorry. So the risks of the anti-tumor necrosis factor alpha are non-Hodgkin's lymphoma. So you've got 2 in 10,000 chance of getting lymphoma in your lifetime. You know, you put 10,000 people in a room, 2 of them are going to get lymphoma sometime in their life. By taking anti-tumor necrosis factor alpha, that risk goes up, again, because it's an infectious process. And when you interfere with the immune system, things get screwed up sometimes. And if you think about it, it goes 2 to 4 times the average rate. So when I tell people, hey, you're going to have 2 to 4 times the risk of cancer, a lot of people are like, I don't want that drug. Okay, then I tell them the cost, and they really say, I don't want that drug. But that really scares a lot of people away. So what you want to do is put it in a graphical format. When you look at risk, you got to kind of put it in the context of the way you look at data. And so here's the baseline. It took a long time to type 10,000 dots, by the way. So there are 10,000 dots on that screen, and you can see the baseline risk of lymphoma is 2 dots. Okay, so in a big herd, 2 out of 10,000 is not that big. That's baseline. So someone who's on some of these biologic therapies, that risk goes up to that. So there's still increased risk of an uncommon disease is still an uncommon disease, okay? But everyone knows someone who's died of lymphoma or has had lymphoma or has been treated for lymphoma. But it does increase your risk. Overall, it didn't take nearly as long to do this. So this is there's 5 people out of 100 will end up with some kind of adverse reaction. That might be just a skin change. That might be anaphylactic shock. That might be an infection. So this is 5 in 100 people end up with some adverse reaction to the anti-TNF medications. So we're going to go down and start talking about this next one. It's actually kind of interesting, 2 drugs that are out on the market right now, the Vedolizumab and Natalizumab. Natalizumab came out first, and the Vedolizumab was recently approved, I think, 2 years ago, a year and a half ago. Okay? And it is an anti-alpha. And the way it interferes with is it interferes, Dr. Schoenfeld talked about the innate and the adaptive immune system. So you send out the invitations with this TNF-alpha and all these other interleukins, okay? And then your adaptive immune system is the one that comes and shows up to the party, okay? So you're trying to get your immune system to recognize this disease, and you're asking these cells and these immune cells to come in to the party and have some fun, okay? So you send out the invitation, so the anti-TNF are the ones that interfere with that invitation to the party. They interfere with the invitation. This next set of drugs take the balloons away that you put out in your front door so that people can find it, okay? So what it does is it blocks those lymphocytes, okay? They've been invited by TNF-alpha, okay? And then this drug takes that balloon away at your front door so they can find the house, okay? So it prevents that immune cell from actually getting to the site of inflammation, okay? Which is good, because you don't want the immune system to make the inflammation worse, okay? So the actual name of this molecule is that I had to write it down. It's a mucosal adhesion cell adhesion molecule, okay? And that's these little yellow things that you see at the top. And this is the drug that is the antibody to that, so it actually hits the lymphocyte and prevents that lymphocyte from actually finding the lining of the blood cell to actually be invited to the party. So again, it's interfering with that, taking that balloon away so it can't find the party. There are downsides to that, though. So Natalizumab, as we talked about, was the first one that was FDA approved for Crohn's disease, and has actually initially approved for multiple sclerosis, okay? Because it is a non-selective It can go into any party. It doesn't matter what neighborhood it wants to go into. So it can go into the intestinal party. It can go into the brain party. Okay, and it blocks that. So it takes those balloons away from both the brain and the intestinal tract. So it blocks that ability for your immune system to find that party. The downside to that, though, is that you kind of need an immune system in your brain, okay? Because there's viruses that can settle in the brain. Usually with HIV patients or people who are severely immune compromised end up with a disease called progressive multifocal leukoencephalopathy, okay? And those are the people that you see on the streets looking at their hand and they can't recognize it, okay? So it's like mad cow disease of the brain, okay? So it interferes and it's an infection in the brain and it causes debilitating dementia, okay? Where you can't even recognize your own body, let alone your neighbors and friends, okay? And you can kind of see the risk of this. This is over time. This is mostly done in multiple sclerosis patients. But you can kind of see the incidence per 1,000, 4 in 1,000 people, okay? That's not a small number. And so as a result of this increase of severe, you're going to die of this disease if you get it, you take special licensing to have this drug, okay? So it is not commonly used for inflammatory bowel disease. So going back to this, they came up with Vedolizumab, okay, which can go into the brain, okay? Or correction, it does not block the brain pathway. It just takes the balloons away from the intestinal tract, okay? So the inflammation, it blocks the inflammation in your intestinal tract, but allows you the immune system to go into the brain and fight this virus that almost everyone has, actually. And in after-marketing studies, the Vedolizumab, no one has ever had PML with Vedolizumab to date, okay? And all the studies, when they were getting FDA approval, they had to be actively watched for that disease. They had to go through MRI studies and spinal taps to be evaluated for that disease. And no one to this date has gotten it. But it's got a response rate, you can kind of see of the patients, 14 clinical remission, placebo is 6, so it's doubled. It's not bad, but it's still only 14%. And then for Crohn's disease activity index, which is that questionnaire that you can fill out, and the response rate was a little higher. It also works in ulcerative colitis. Again, the response is a little bit better in UC patients. And this is a dosing trial that was done. That's why you see the 2 milligrams per kilogram, 6 milligrams per kilogram. And so all the dosing kind of works for ulcerative colitis in the Vedolizumab group. Okay? So getting back to this bowel functioning again, there's another drug that came out that is actually FDA approved for psoriasis and psoriatic arthritis, and it interferes with this other calling card, or this other invitation, interleukin 12 and 23. Interleukin 12 and 23 are kind of cool because it's interleukin that share a common protein, and they kind of run around together. And it is called Ustekinumab. It's Stelara is the other name of the drug. It is FDA approved for psoriasis. It is not FDA approved for ulcerative colitis or Crohn's disease yet, but the trials are in process, okay? So you can kind of see the response rate is actually really good, so it's just as good as Infliximab, Remicade, or Humira, okay? And the risks are actually very, very tolerable, okay? I want you to just do all patients rather than the 2 different doses. But you can kind of see they're very close to each other. There's not really a statistical difference in any of these risks, okay? There's one person who did have a malignant neoplasm, lymphoma, with this drug, okay? So the next one, so this, again, this is not on the market yet for Crohn's disease. There are case studies and case reports of people using it, and people have responded, okay? And again, it's just probably a matter of time before it gets approved by the FDA. And then we're going to talk about interleukin 4. This is a cool drug. It's already FDA approved for rheumatoid arthritis, okay? But it interferes with interleukin 4, 9, 5, 1, and 23, or 21, one of the 20s. And so, but interleukin 1 is on this graph, okay? Or interleukin 4 is on this graph. And again, the way it works out is that this is the calling card thing that we talked about, and this is the monoclonal antibody. So this is like the TNF-alphas. The anti-TNF-alphas will bind the cytokine before it gets to the cell where it needs to go, so it blocks that invitation. The other one we talked about blocks the balloon, so you can't find the party. This one actually blocks the transcription of, once the cytokine gets into the white blood cells or the immune cells, it blocks the ability of that cell to actually use it. Okay? So it receives the invitation, but then it loses the invitation in the process, and you don't know where the party is. All right? And you can kind of see the response rate for this as they got more mature. So they said, here's the clinical response is actually up to 78%. Okay, at 15 the higher doses. The clinical remission, endoscopic, so they're actually starting to do endoscopic evaluations for mucosal healing in these patients. And then the endoscopic remission is only about 30%. Okay. And again, it is also a very safe medication. You can kind of see that everyone talks about infection, 7 versus 6%, so it's really on par across the board. And again, you look at the numbers here again, so the number they put in these are only 30 per, so this is only an early phase trial, so they haven't had thousands of people on these drugs yet for inflammatory bowel disease. And going back to this one, you want to see this is only 180 patients that were given this drug that we talked about earlier. So you're still looking at not thousands and thousands of people to get these big databases to find out the bad side effects that can occur. So it's still in its infancy when it comes to IBD.
How are the people selected for these trials? Are they really sick already and have failed other drugs, or are they?
Most people are naive to TNF-alphas as their requirement to get in, because they don't want to mix and match and increase their infection rate. They're trying to have a nice, pure subset of patients.
And they're probably at a big research.
And you either live in Mayo or you live in Southern California.
Are these drugs administered the same way as other anti-TNF drugs?
They're infusions, yeah, or injections, yes. We're going to talk about a pill later on. So we're going to talk about drugs and biologics. So this is the FDA's definition of a drug. I'm going to read it, so I apologize. But it's going to say articles intended for use in the diagnostic, cure, mitigation, treatment, or prevention of disease. Articles other than food, so that's why all these probiotics are considered food supplements. That's why they're not regulated, and that's why it's like a Wild West out there. Hey, take this biotic, I make money off this, do that. But other than food, intended to affect the structure and function of the body of man or other animals. So that's a drug. So a biologic product, so we're talking about biologic therapies now. A virus, therapeutic serum, toxin, antitoxin, vaccine, blood component or derivative, allergic production, protein, except other chemically subtilized polypeptide, or analogous product applicable to the prevention, treatment, or cure of a disease or condition of human beings. So everyone's talking about Ebola. So the doctor who survived Ebola from Atlanta gave his serum, to the nurse who was sick from Texas. Okay, so that was a biologic product. Okay, so they actually had to get approval from the FDA to use that. So it's interesting. So talking about the fecal microbiota, there was an issue about fecal transplants for C. diff. So when used to cure, treat, mitigate, or prevent a disease, fecal microbiota for the transplantation meets the legal definition of a drug or biologic product. It's kind of fascinating when you think about it. So I cannot give anyone poop because it's considered a biologic therapy. But I can give them a probiotic because it's a food supplement. So systemic review, this is fecal microbiotic transplantation in malignant and management inflammatory bowel disease. So they took 41 patients. Again, these numbers are really low, so bear with me. For UC, Crohn's, and unclassified, over half had a reduction in symptoms. 13 out of 17 were able to come off their medications. And almost half, over half had complete disease remission. So essentially they took poop from a healthy person and infused it into a sick person with ulcerative colitis and Crohn's disease, and reset that microbiome, which we'll talk about this afternoon, to something that was not so pathogenic, or that your immune system didn't recognize as being bad.
Do you know if they've done any of that for J pouches or anything along that line?
I'm sure the studies are out there. I haven't been looking up to get ready for this talk, so I don't know.
Is that a one-time thing, or is it they have to be routinely?
Most of the people that are doing this do it for like a 2 or 3 week period, and then do like monthly or bi-weekly infusions.
So it doesn't reset on its own?
No, it doesn't. It's not a permanent fix. And
Unless they go
UC works much better than Crohn's.
Unless they go online and they're kind of doing it on their own because they're not getting the help they need from the medical.
Well, you know, I used to work with someone who was kind of off the beaten path, and we sent him to Japan because he was that far off the beaten path. So he actually had a lot of his patients doing this. He had like 7 patients doing this. But he could teach them how to do it. It's illegal for us to do it in the hospital because it's a biologic therapy. So you can show people how to do it. You got to buy a special blender, well, that you don't use for
It's
other
on
food.
YouTube.
Yeah, you can go to YouTube and you can do it. So.
Okay, unless they do not do a home.
So you got to. Yeah.
We're not saying that.
Yeah, I'm not endorsing this. I'm just saying that this is a biologic therapy that. Hold on one second. So it's actually coming out of the poop pill. So and so the Crohn's Colitis Foundation in America is actually sponsoring some of these biome things.
It's more commonly used to treat C. diff.
Yeah. So they come out with the stool transplantation pill. This is for C. diff, but it's going to probably be expanded to inflammatory bowel disease. I hope they make it brown, so at least it's marketing better than the white food pills that they have there. So, but it's clear. I mean, you have to make sure you can't just go out there and find someone, because if they have Giardia, strongyloides, if they have other bacteria that are not necessarily good for you, it can really, really make you sick. So there's a process that has to be involved in this. So I'm not telling you to go out and find your best friend and ask him to donate a steamer. But, the other one. Sorry. I've given this talk a lot, and I always laugh at that point. This is the whipworm. You've got the male and female. You can see the female is more dominant than the male in the whipworm world, because she's bigger.
That's not just the whipworm.
So they actually infuse whipworms into Crohn's patients. And again, if you go back, sorry, I'm supposed to put this in there. There's this whole intestinal parasites that we grew up as a species that we're supposed to have. And one of the theories of the industrial age is that we're getting cleaner and cleaner. The hygiene theory is that our immune systems are bored. And so that's why we're seeing an increased rate of these inflammatory bowels and these autoimmune diseases. And so someone came up with the idea, if we induce whipworm, a worm that's been around, since the Stone Age and beyond, earlier than that, that it actually give our immune system something to do and divert it from attacking us in our intestinal tract and have it do something useful. And they actually had 23 patients, almost 80% respond. Okay? Again, low numbers. But like Dr. Shanefield was saying, there's no money in this. No one's actually going to sit there and say, hey, let's go get these whipworms and infect a bunch of people, because there's just no marketing. There's no one has a dog in this fight except the whipworm. So this is a pill that we were talking about earlier. It's one of those receptor antigens that you can take it, and it prevents the it prevents the attraction of these immune cells. Okay. Don't write this down. The initial was bought by ChemoCentryx, is the one who developed it, and then it was marketed to GlaxoSmithKline. Oops. Sorry. But they stopped because it didn't work. So, the only pill that was actually pretty hot and heavy a couple of years ago, everyone was really excited about, SmithKline has withdrawn the study. Anyway, not then on a bad note.
Thank you.
Actually, I have a question for you about the biosimilars they're talking about, like as next stages of these patents and whatnot.
Okay, so again, I don't have any first-hand knowledge of that, but one of my friends is on the National P&T Committee for the DoD, Department of Defense, and we spend an awful lot of money. So my institution where I came from, we prescribed more Remicade than any other facility in the country, more than any other VA. And so we went there and said, hey, is Remicade going to come off, because it comes off patent, I think, next year. Is there any, is it going to be made in India, China, somewhere cheaper? And the answer to that is no. There's no generic pharmaceutical company that has taken an interest in mass marketing biologic therapy on cheap.
I thought there was one that just filed something out of China.
That's why I'm just
I
saying
don't know.
I am a third-hand kind of information. So because the DoD obviously doesn't want to spend any money, and they go for the lowest bidder. And right, the meeting that he went to a couple months ago, there was no talk of it.
Question: are there blood tests that you can do to determine what biologic would be best for the patient, or is it just trial and error? There's a couple genetic tests that are out there, but I don't know of any trials that say, hey, because at the time, there's only one. No. Hold on one second. If you look at the number of drugs that are FDA approved, it's really hard to. So there's, it's only these two categories of drugs. So, and this one's, no one's going to use Natalizumab because of the PML risk for inflammatory bowel disease. So, and Vedolizumab, it'd be nice to have them do that study, but they just got their FDA approval, so they're out there trying to market their drug, and then to tie it into a genetic predisposition. Hey, use this drug because you've got this gene. Those studies have not been done. So, like I said, there's 70 genes. NOD2 is the most common one. But there's no test that you can say, hey, use this drug over that drug. So, because there's just not that many choices. There will be, like 10 years from now, I imagine there'll be something like that. Yes, ma'am? Are any of those biologics pill form?
Nope.
No.
Injection or infusion. The only pill was the one that I talked about. Everyone's really excited about that JAK2 pill. Yeah. No, the one that didn't work, that GlaxoSmithKline took off the market, or stopped the trial early because it wasn't working.
Anything else?
Has anybody ever used whipworms?
Other than that trial, I don't know anyone. I know it's only in Europe that I've seen any studies out. It's not been done in the United States.
I think another thing to note on that is that it has to be pig whipworm, because if you have human whipworm, then it can survive in your system and you can't get rid of it. With a pig whipworm, you pass it. So it's more of a therapy, a long-term therapy. Anything else? Well, thank you again, Dr. Gentry.